Respected judges and my dear friends, my study on repeatability and reproducibility of ocular surface thermography, supported by Biotechnology Ignition Grant. As we all know, dry eye disease is a multifactorial disease characterized by loss of homeostasis of tear film. The main diagnostic challenge is that symptoms often do not correlate with signs. Ocular surface thermography measures ocular surface temperature patterns and thermal dynamics. Our study hypothesis is that changes in ocular surface temperature may indicate loss of homeostasis of tear film and which could help to detect dry eye disease. The aim of our study is to validate the repeatability of ocular surface thermography with infrared thermography system in the diagnosis and monitoring of dry eye disease. We also studied the correlation of OST with other diagnostic tools like OSDA questionnaire, Oxford staining, shimmer test, and newer diagnostic tests like interferometry dry eye research analyzer, that is IDRA. This was a prospective cross-sectional study done at a tertiary eye care hospital in Kochi. The sample size was 53 and was calculated using this formula. Our study population consists of healthy volunteers between 20 to 40 years of age, and these are my exclusion criteria. The subjects underwent routine tests for dry eye workup, starting with the least invasive tests like OSDA questionnaire to more invasive tests like shimmer test and Oxford staining. The OST were repeated 3 times. Objective tests like IDRA and OST were performed in a standardized environment with a temperature of 22 degrees Celsius and relative humidity of 50%. A non-contact infrared thermography camera measures the temperature distribution of anterior ocular surface. A series of images were taken during the test. Post-blink red areas represent warmer regions with uniform tear distribution, and with evaporation, cooler areas appear on the cornea, which is represented by yellow to green color. The average age of our study population was 26 years with symptom score of 19. IDRA showed non-invasive breakup time of 8 seconds, lipid layer thickness 48 nanometer, tear meniscus height 0.3 millimeter with 20 to 30% meibomian gland loss. The mean shimmer was 20 with majority of eyes having minimal or no stain. On OSTA score, 62% of participants were normal, 9% had mild, 4% had moderate, and 25% had severe dry eye disease. Individuals with normal and mild to moderate OSTA scores produced consistent metrics with good repeatability on intra-class correlation coefficient, while those with severe dry eye disease on OSTA showed poor repeatability. A failure to maintain ocular surface temperature homeostasis could also be used as a surrogate measure of severe dry eye disease. The demographic differences were statistically not significant. Among IDRA parameters, lipid layer thickness showed a significant increasing trend from normal to severe dry eye disease, suggestive of aqueous deficient dry eye disease rather than evaporative dry eye disease. Lower lid meibomian gland loss showed a worsening trend but was not significant. Other parameters of IDRA showed no correlation with signs and symptoms. Oxford score was significant between groups but not strongly linked to severity. OST showed statistically significant difference between groups, correlating well with severity. Receiver operating characteristic curve is a graphical representation of the discriminant capacity of the test. IDRA and clinical tests were about 50% accurate, while OST had an area under curve of 86% to differentiate normal from dry eye disease. IDRA and clinical tests again showed 50% accuracy, while OST showed 88% area under curve to differentiate normal, mild to moderate dry eye versus severe dry eye disease. Earlier studies done by Petsnick, Lilitan, and Kamau reported good repeatability and clinical value of OST. Our study agreed thermography is a reliable tool for dry eye disease evaluation. So, ocular surface thermography measurements were repeatable and reproducible. It is truly non-invasive tool for dry eye diagnosis and monitoring. Its measurement had better discriminant value than conventional clinical tests and advanced diagnostic tools. Future works include faster and bilateral imaging, more accurate temperature calibration, and to validate cutoff for dry eye disease severity. These are my references. Thank you.
Thank you, Dr. Dhanya. So, very nicely presented. 25% severe dry eye is quite a significant number, and the mean age was 26, 27. And what do you think was the reason in those patients? They were otherwise non-ocular surface disease patient, normal population. So severe dry eye in 27-year age mean population. So what was the reason? Did you further investigate?
Maybe digital eye strain.
But severe dry eye, you mentioned 25%. So did you further look into the cause? What was the reason for that?
Layers multiple dynamics, no? The tear layer. So you yourself stated that drying or rather evaporation of the tears, aqueous component of the tears is the cooling factor. That is what creates cooling. Then it will be obviously varied between the different dry eye varieties. So that didn't come out in your data. Your data is more complex than it just showed you are trying to test repeatability or rather whether you can use this test in that array of tests which is done for a dry eye. In that way, will it be varied between the different subgroups of dry eye is another important factor which you have. That if it is tested, probably as you are doing it with DST, I'll advise you to do that also and see whether that repeatability and reproducibility is good across all the segments of dry eye. Aqueous deficiency ones, the lipid deficiency ones. You are trying to brush all together. Don't do that. Make them separate and do. Okay.
The stringent details regarding temperature and humidity, right? 22 degrees and humidity of 50%. So do you have a separate clinical room isolated for this machine? How do you
No,
maintain?
ma'am, we used an hygrometer to measure temperature and humidity.
Okay, we done this. How do you? I mean, in your clinical practice, consequent other patients, have you used this machine to assess their dry eyes? Have you been able to maintain the same stringent requirements?